Dr. Stephen Porges, welcome to the show.
Well, thank you very much for inviting me. Looking forward to it.
Been looking forward to this conversation for a long time. I'm such a huge fan of your work, and it's really an honor to get to spend some time with you and ask you some burning questions we've had for a long time.
Fire away.
Well, so our audience is mostly therapists, psychiatrists, mental health providers in general. And for those in the audience who haven't heard about the polyvagal theory, we thought we would just ask you to give a summary and a kind of introduction, walking us through the basics of physiology and implications in regards to presentation, that kind of thing.
Well, it's my least liked question, but I will go with it. We have to think of what we come on the planet with, in a sense, our toolkit, functionally our neurophysiology, our nervous system, and especially in polyvagal theory, the neuroregulation of our visceral organs through the autonomic nervous system. And this is really organs in the body and a brain structure in the brainstem regulating those organs. So polyvagal theory is functionally a brain-body science. And it really emphasizes the bidirectionality of information from the organs to the brainstem and from the brainstem to the organs. And so you don't have any separation of mind or brain function from bodily organ function. So within the world, of course, of psychiatry, people talk about comorbidities. Polyvagal theory says they're merely expressions of the same system in different ways. And you often find disorders in the gut, like irritable bowel syndrome, being comorbid with trauma. You often see also gastric and GI problems with anxiety disorders. And we tend not to understand that we're talking about a physiological system that has reacted to threat. And that reaction is predictable. So polyvagal theory really emphasizes and describes the evolutionary journey that an asocial reptilian species transitioned into social mammals. So how did this occur? Well, it occurred with changes in how the autonomic nervous system was regulated, because social mammals had to turn off threat responses, and they had to do that rapidly. So they had to be able to detect cues of safety. And those cues of safety were adaptive and reflexively downregulated our defenses. So just visualize a mother talking to her baby or singing or using a hyper-prosodic voice with intonation versus someone saying the same words, but now in a monotone. Our bodies respond very differently. In a sense, we have the template for what are cues of safety, and modulation of voice is one of those. Facial expressivity is another. Gesture. They're part of a system that was this social engagement system, which was the neuroregulation of the striated muscles of the face and head. But that system in mammals became connected in the brainstem with a uniquely mammalian vagal pathway to the heart, which basically downregulated threat and sent signals to the subdiaphragmatic areas of our body: do your job, don't react to the threat. So when our bodies go into states of threat, we're not getting the signal to the lower part of our body saying, do your job. So enteric system is a big flag. But the real issue, if we want to really strip it away, there are two things I would like you to take away from this. One is, through evolution, social behavior or interaction with another is functionally elevated to a neuromodulator. So it's literally a neural stimulation. It's not social behavior. That's fine. Don't waste my time. We're dealing with hard science or neurophysiology. But in mammals, social behavior is a neuromodulator. It's elevated. There's this interaction in the body between social behavior and physiological regulation. It shifts states. That's the first thing to take away, and in a sense, get a grip onto, because it's so powerful. It means that social interaction or social prescribing, which is now words that are used in psychiatry, is really a powerful neural stimulation metaphor. And it's a neural stimulation to turn off threat systems and to optimize systems of homeostasis. So it's homeostasis in the mental world, and homeostasis in the organ world. So they're intertwined. So that's, in a sense, to understand that evolutionary trajectory, that we have this toolkit that detects threat and shifts our physiology, and we detect safety, which is the gift. We detect safety, and that turns off our threat. And so we start to recognize that physiological state that we're in is this intervening variable, powerful concept. It's in between the external world that we're responding to and our own responses. Based on that physiological state, your responses will be biased towards being defensive or being welcoming and accessible. And if we, in a sense, ask people how they feel and they had a language to describe feelings, you'd find out that for many people, much of their life is all about suppressing feelings, becoming numb to their body. And from a neurophysiological model, that's turning off your feedback loops. And guess what? What you see in the medical metaphors of this, or manifestations, you see the feedback loops are malfunctioning, and you see that's when you see disease being expressed. So I'm sorry, I kind of rambled on for a while, but the emphasis is really sociality is a neuromodulator. Our physiological state is the intervening variable between what's going on in the world and our reactions, but our physiological state becomes a portal of intervention to change the biases.
Well, that was an incredibly pithy overview of a very complex system. And I can understand, I guess I'm guessing that you probably don't love that question because you probably get asked all the time. Can you summarize this?
Well, it's worse than that. I don't know where I'll go with it.
Okay,
So what you heard was the first time I scripted it that way. So it's not a reflex for me, because if I get scripted, then why do podcasts? Why do interactions? What's the benefit to me? I'm not enjoying it. So I like the So as I said, social behavior is that neuro moderator. I want it.
Thank you. I'm curious, just a little bit deeper down the rabbit hole of neurophysiology around the dorsal vagal, which, as I understand, is more the reptilian.
We have to be careful in a sense, compartmentalizing. So the major part of this, it's dorsal and ventral, because that's the part of the brainstem, dorsal or ventral, where the cells of origin of this pathway come from. So it goes into a conduit that we call the vagus. The vagus it's a tube, with pathways. And unfortunately, in the popular press, the vagus is being treated as if it makes decisions, it has executive function. You want to hack it, you want to tame it. It's a conduit, it's a cable with pathways coming from these three areas, because it's two that are motor, and then it goes to one that is sensory. And it's functionally 80% of the fibers are sensory. So it's your surveillance system of your body. And you have to think of it as this major regulator of your organs. And we have the dorsal. Now back to your issue, dorsal and ventral. The original vagus in vertebrates is dorsal. And then through evolution, primarily in the transition from reptiles to mammals, there's a migration of cells of origin of the vagus, of the cardioinhibitory fibers of the vagus, that move to this ventral area that's regulating the muscles of the face and head. And if you look at it in that way and say, why? What was the adaptive function of this movement? And you start realizing that our social behavior now became intertwined with the regulation of our cardiovascular system. And so it has the capacity to downregulate threat reactions. And it was, in a sense, evolutionarily prioritized, meaning that there's a hierarchy. And this is not polyvagal in originality. It goes back to John Hewlings Jackson, who was a neurologist at the turn of the 20th century. And what he was saying is that when you get brain damage, older circuits start expressing themselves. And he called that term dissolution. And I took that concept of dissolution, modified it for polyvagal theory, and said, under challenges, not under damage, we basically go through older evolutionary stages. So we lose that newer ventral circuit, and the next one that came in Before that one was our sympathetics, spinal sympathetics. And so when we, in a sense, lose our accessibility and we become vulnerable, we become defensive, which means we become mobilized initially to fight or flee. You see that in psychiatry as anxiety, tightly wrapped people, irritability, inability to sit still, high-risk behavior. You see the whole portfolio coming out. And you also, with that, will get symptoms like tactile hypersensitivity and auditory hypersensitivity. And the auditory hypersensitivity is because the neuroregulation of the muscles of the face and head include the middle ear muscles. And when they're tense with the neural tone, they dampen out background sounds. But if you're under threat, what do you want to hear to survive? Low frequency predator sounds. So everything becomes adaptive and not pathologized. So, and then the oldest circuit is when the sympathetics no longer get you into a safe place, you shut down with that old dorsal circuit when recruited in defense. But the sympathetics and dorsal, we don't want recruited in defense. We want them, in a sense, contained in a sense of safety. And that's where that ventral vagus creates the boundaries that enable the sympathetics to be fine. So we play, we don't fight or flee. We're playful, we move and we smile and we play with others. And when we immobilize, we're not shutting down. We're having moments of intimacy and trust in other people's arms. So the ventral vagus is, I use the terms, I started to introduce these terms in an interview, and then I had to figure out what I meant by them. So it's like, this seems like interesting. I said, the ventral vagus is both a cheerleader and a choreographer. The choreographer is clear that it keeps it within certain boundaries, these other systems. The cheerleader is that we become accessible, we become mobilized, we expand, life becomes meaningful.
I like this so far. Let's expand on this concept of down-regulating threat. Mm-hmm. So if we think about sort of an individual, let's say that we would say is more highly traumatized, a lot of PTSD, and how you describe polyvagal theory and this neuromodulator and downregulating threat. Are you saying that the person who is traumatized, all that's happening is that their ability to downregulate threat is impaired? Is that what you're saying?
Well, we want to be careful in using words like impaired. We would say their capacity to detect threat is enhanced. You see, if you flip it around, it's like a body that's been injured isn't going to go back to the same place to be injured again. And with many individuals who suffer from trauma, is a violation of trust and safety with another person, which is what is the result or created the traumatic event. And so you find that with people with trauma histories, if their bodies start to relax, start to become accessible, they immediately react to that vulnerability and get highly anxious, mobilized, and destabilized because they don't want to be there. So even though on a conscious, intentional level, they want to be there, their body says, no way, I know what that will do to me. And in a sense, you have this, I would use the most dissociation or disparity between our different intentionalities, the intention of a body, nervous system to stay safe and alive, and an intention of our narrative, our cognitive view of what it is to be a human, to be safe in the arms of another.
Maybe you can kind of expand more on how does the social engagement system detect safety versus threat? What's actually happening there?
Well, let's say that the social engagement system is really downstream. So it's really structured from the neuroanatomy, and it's the neuroanatomy of certain pathways that evolve to regulate structures linked to the ancient gill arches. So it's an integration already in the brainstem that the muscles of the face, the muscles of the larynx, the muscles of the pharynx, and the muscles of the middle ear are all part of the same system. And it's a system of, in a sense, ingestion with the newborn baby. And it's also a system that is later modified and used as our primary social engagement one. So in the world of some of the psychiatric disorders, you'll see eating as a disorder. But if you see it from the lens of polyvagal theory, eating disorders are valiant attempts to utilize the social engagement system to literally engage it to calm down. So it's the sucking, swallowing, ingestion that is calming, chewing gum. These are strategies to calm down. So you really want to know, how's it detected? The detections are actually at a higher level in the brain because they're dealing with detection systems. And the issue is where in the brain. And I've been very interested in this process that I labeled neuroception, which was the nervous system's detection of risk in the environment. And it had, when I started to come up with the construct, I was playing around with like emotional perception. And then I realized if I drop the word perception in the dialogue, I'm in trouble because people will start blaming themselves for not perceiving, because we think of perception as having a cognitive, or at least a degree of awareness. And if we don't, we think we can learn to be more perceptive. So I wanted to give the agency to the nervous system without awareness. So I called it neuroception. And I think the important part is to say the nervous system evolved to detect threat. And the part is all vertebrate nervous systems detect threat or have a nervous system, a neuroception of threat. But mammals have this unique neuroception of safety. And when we see that, we realize that removal of threat is different than detecting safety. And then we start understanding the politics of the world we live in, which doesn't make any distinction between cues of safety or removing of threat. We think that arming people with guns removes threat and we'll be safe. I'm not saying that removal of threat is bad. I'm saying our nervous system is not satisfied with that. It wants something else. It wants cues of safety. It really craves that. So if we start asking questions like where in the brain would this occur, I initially start to think that areas of the temporal cortex were important because they detect features of faces, familiarity. And so it is that areas of probably temporal cortex are going to detect features of intentionality. And that's going to now go downstream to the brainstem and say, based on intentionality, I better shift my physiological state from accessibility to defensive.
Is on a very basic level, is the brain interpreting a pain versus a pleasure, and it's saying pleasure is safe and pain is threat? Or what's like, how is that not even a good construct to talk about?
It's interesting. Listen, everything's interesting to think about. And I was pulled into a group of pain physicians and psychologists who were interested in polyvagal theory, and I had not thought much about pain in general. And what they were trying to tell me is that when they start to apply principles of polyvagal theory, their clients became pain-free. And it took me a while to really, not a while, it took me a couple hours of interacting with them. Then I got the aha moment. And I said, of course, because pain is a cue of threat, like you're describing. Physical pain is a cue of threat. So that means your body's in a state of defense if you are in pain. So some of these insightful people decide that if this were true, they could do techniques like breathing and or social interaction and group psychotherapy, and their clients became pain-free. So in a sense, the clients were now able to regulate state through another mechanism, and that mechanism shifted to them into a state which was incompatible with being in pain. So going back to your question, I don't think the word is really pleasure. See, we start getting into reward systems. I think it's more linked to our biological imperative. What does our species need to survive? The species needs to be safe in proximity to another. That's our history. And once we're that way, we have cooperation, we have creativity, we have, in a sense, the ability to solve problems through cooperation. Yet our society is so contradictory to this biological imperative. It's always the individual that is fostered. Yet our bodies like to feel safe in the arms of another. We want to trust. And, we end up with these, I think, false narratives of tough love. It's a rough world out there. Our bodies want to feel safe with others.
This question might feel really off the wall, but I'm going to go for it anyway. I've always wondered, humans clearly are social primates, and no argument there. Chimps are social primates. Lots of monkeys are social primates. Is there something different about an orangutan that it wants to live in the forest by itself and come and mate with another orangutan and then go back in the forest? Do we know anything about why that animal's not social?
Okay, if you were interviewing my wife, and you probably should, and my wife is Sue Carter, who discovered the relationship between oxytocin and social behavior.
Oh, wow.
And so she would probably go from a molecular or model and start saying different degrees of oxytocin enables them, they need, in a sense, to be by themselves, at least for a while. But remember, even solitary primates or solitary mammals have a period of dependency, a maternal dependency, in which they have to be taken care of. So there are different stages here, and part of the problem I find with our understanding of human development and the educational model is that we basically want self-regulation too early. And the sequence is that if we have access to good co-regulation, good parenting, the neural systems of regulation develop naturally, and then the person can have capacity to be self-regulated. And we tend to get this all mixed up. We see it as smothering and all these others, but we have to think in terms of neural exercises of getting regulation into the system. Often in my talks, I show a picture of kittens playing, and I reflect on the picture because I saw these types of pictures when I was in graduate school, and they used to say, "Oh, the kittens are learning their fighting skills." And now with the lens of the polyvagal theory, I look at it as, now you got it all wrong. The claws are retracted. They don't break skin. They don't bite hard. They are learning skills of self-regulation. So they're learning to regulate their bodily states through play, which is the difference than aggression. Play is movement in a safe environment. And these animals are learning that neural exercise that gives them this tremendous range of regulation.
So if a person is, had a difficult attachment period, let's say, and they're biased in regards to what they're expecting in a social engagement. They tend more toward defensiveness. They have this touch aversion or exaggerated startle. They have trauma in their system. It seems to me, and I'm curious, I'm sure you've thought about this a lot, is with the vagal nuclei in the brainstem, are we talking about different tonality?
Well, I think I know where you're going. You are, I think, asking about reversibility. Yes. Or in a sense, is this a destiny, a temperamental? Let's start off by saying, whatever I talk about is going to have an optimistic narrative, because it's really focused not on neuroplasticity, which is the other part of your, I think, assumption. It's based upon state changes with the potential of shifting state and the neural flexibility rapidly being recovered and growing. So we have to understand that there are state changes. I mean, especially in the world of trauma, we buy into the fact that a person can be jovial, interactive, and seem real buffer on one day. Then a traumatic event happens. The person can't even walk up a flight of steps, can't be near another person, can't be touched. So we know there are massive state changes that can downregulate the system. And we know that it's not neurogenesis. It's not going on. It's a reorganization or retuning. And the question now is, can you recover that? And, we talked before about your practices in somatic experiencing. Somatic experiencing takes the role that you can reawaken those circuits, but you have to titrate or pendulate, as they would say, because and I think I understand that now from a different level. The reason you have to is that cues of safety become cues of trauma. So the person their body has to be comfortable with feeling accessible. And so I'm extraordinarily optimistic. But let's clarify part of your point, because you want to get into the notion of tonality. And when we talk about the vagus no longer being able to downregulate threat reactions, what do we really mean by that? Well, there are two things that we would find in the person's autonomic profile. One would be the measurement of cardiac vagal tone, which be extracted from heart rate variability measures. And that is really a very powerful and accurate index of what's coming out of that area of the brainstem. So if you have more respiratory sinus arrhythmia, more changes with breathing, you have more cardiac vagal tone. But I started to work on another metric. And this metric I call vagal efficiency. It was not only how much apparent vagal tone do you have, but how effective is it in regulating your heart rate? So I was looking, with a well-tuned, typical, not diverse person, but a typical person, you find if you're not in a state of fight-flight, your heart rate is primarily being regulated by moving the vagal brake on and off. You're basically using that ventral vagal tone, and you retract it, your heart rate goes up, you walk around, you sit down, and now your heart rate comes back down through a vagal recovery. But now I start to find people but who their heart rate patterns were unrelated to their heart rate variability regulation. And it was always the same thing. They had symptoms in the medical world of dysautonomia. And a person, I'll give you a few examples. So we can start off with where I discovered this. I discovered it initially looking at newborns, showing that in different sleep states, they had different coupling or different vagal efficiency. Then I moved it to what happens when an adult drinks alcohol. Well, the vagal efficiency drops. Makes sense now. Then I did a study on prematurity and showed that it developed. You could see it developing. Then we did a study with Ehlers-Danlos syndrome, which is a hypermobility syndrome. I thought it was rare, but you see it manifested in many clinics, including gastroenterology clinics, where we found out that 50% of the adolescents in this pediatric GI clinic would fit the diagnosis of EDS, Ehlers-Danlos. Most of them were not even diagnosed. So by doing the testing, they had very poor vagal regulation, vagal efficiency. And even though they overlapped in terms of gastric pain, functional abdominal disorders with those without it, the vagal efficiency was significantly lower than the others. And with Ehlers-Danlos, one of the common themes that comes out is dysautonomia. And it's often frequently misdiagnosed, but what we're really trying to say is there's a neurophysiological component of the symptomatology. So and then in a normal study with people with mild trauma histories, not PTSD, they had significantly lower vagal efficiency. Now, I will pose that within a medical model because what is the vagal efficiency telling you? It's telling you about the effectiveness of a feedback loop that the vagus is involved in that regulates mobilization. It regulates heart rate to get you into different places. You need to regulate heart rate to move. So what we're saying is that the feedback loops are depressed. Now, what does that mean in general? If it's a marker for general autonomic feedback loops, then it is dysautonomia. Because what it really means is if your feedback loops are not efficiently working, you'll end up getting end organ disorders. And this is the fallacy or the vulnerability or weakness in medicine. It's end organ focused. Disease is located in the organ. The neural regulation of that organ is irrelevant. But if you think about it, the neural regulation, this deficit has to precede the end organ damage. So what you're seeing with this type of measure is most likely an antecedent of what will end up as end organ damage. So the optimistic part that I'm still dealing with is, can you reverse that? And can you now re-engage through what I call neural exercises to reconnect or recouple the system into a more efficient system?
Wow. Thank you for that. I'm just, my head is spinning thinking about all the ways that this is relevant to the patients that I see, and also my own life, my own experience of having quite a few ACEs in my ACE score, and then dealing with kind of watching my blood sugar kind of dance on the edge of, what's happening in the end organ there.
Yeah.
Around, excessive sympathetic tone in my system.
Yeah. So from a polyvagal perspective, ACEs is important, but it's not the real issue. The real issue is the impact of the ACEs on the neural regulation of the autonomic nervous system. So even though you're upping the risks of a retuned autonomic nervous system, it's not asking those questions. So I feel that ACEs is a good start, but the next start is at least survey questionnaires on physiological responding. We developed the scale. It's on my webpage. It's called Body Perception Questionnaire, and it really asks people their subjective ratings of their own internal responses. And it's organized so above the diaphragm and below the diaphragm. And we're finding this to be very powerful in our survey research model, because if you take not ACEs, we were using childhood trauma questionnaire, and then we developed our own adversity index. It does predict lots of things, but if you measure also that subjective measure for the autonomic nervous system, the subjective measure of the autonomic nervous system accounts for virtually all the predictive variance of those traumatic indices. So it's a pathway through that results in a retuned autonomic nervous system. So reflecting it on your own personal experience, your ACEs scores probably had an impact on retuning your autonomic nervous system. Now, with that information, it starts to lead you into portals of intervention more likely than just saying, oh, you've been traumatized, you have risk for all these things. It says, well, you have a trauma history, but that trauma history has left its footprint on your nervous system, and your nervous system is now very well positioned to be defensive. But this is the baggage that comes with that defensive mode. So it's not an anger at your body. It's understanding that your body is really primed to fight off a predator when there may not be one. And that's your job, is now to re-educate the body. And that's, in a sense, I believe what was SE was all about somatic experience, is functionally a re-educational model. In fact, virtually all the effective trauma models are all about welcoming the individual back into their body. They're journeys of re-embodiment. So we start connecting our feedback loops again.
I think you mostly just answered this, but maybe you'll say it in a little different way here. When doing a proper assessment on the degree of trauma someone might be experiencing, are you saying that, like, you would, maybe you would do your childhood history, you would do maybe this questionnaire you have, ACEs, to come to a formulation? That's not necessarily just like, okay, let's check off the symptom list.
No. Let me first make a strong statement. I'm not a therapist, okay? So you can take whatever I say in any way you want. But there are people who have developed intervention strategies based on polyvagal theory that have been very effective dealing with people with trauma. And one is Deb Dana. And she's a remarkable therapist. She never talks with her clients about their trauma history. She talks about their physiological or subjective feelings of their body. So her therapeutic strategy is for people to be comfortable in their body and to experience the range of feelings. And then the emergence of that skill set or that regulatory capacity enables them to move on, or in a sense, to deal with life in a more resilient way.
I think what I'm hearing there is so we're also we're speaking to a sort of philosophy of how to speak about experiences and conditions, and I hear something destigmatizing when let's just talk about the physiological.
Your feeling. Let's talk about your feelings. Let's understand your body. Let's take that psychoeducational journey together where we learn about your body and how you feel. Let's explore you. Now, there's something you brought up, which I think is extremely important to discuss, and that is when someone suffers or survives, let's use the more positive terminology, survives trauma, they often don't want to talk about their trauma, because in talking about it, they see reactions in others and they feel that they're hurting others. So it's a real complicated space to be in, to be supportive, empathic, compassionate, and just allow a person to talk about their own feelings and experiences. And I think as a mental health provider, our mental health provider world, we haven't spent enough time developing a skill set to be witnesses. In a sense, just to listen, to be present and to listen. And you start hearing from different, threads or of therapies in which people, therapeutic presence, people come up with terminologies that they're really saying, this is what's helping the most. Where I'm present, I'm become a co-regulator because I'm not evaluating the other person's experience.
Mm-hmm. Yeah, it's especially lacking this skill set you're talking about in the medical community. We're not taught to do that, in medical school, and I think there's a lot to be said about making the choice, or we were talking about medical education a little bit before we got on this call about how do we actually help physicians to sit with the uncertainty of emotional states that are unfamiliar or discomforting for them even to sit with in the service of co-regulating.
Yeah, because so the first thing is, and this is something that you're going to acknowledge immediately, is that most physicians are under time pressure.
Right.
Most physicians are being evaluated by their patient load and the amount of time and whatever, they're run by MBAs. This is what I've been told, that the whole medical profession has been corrupted from the compassion perspective by the financial drive to basically make money through medicine. So the issue is, if the physician is under a state of threat, they're projecting that to their client. They're not going to be accessible and they're not going to be supportive. So you now have this really a contradiction about intentionality of wanting to be helpful and not being allowed to be helpful. Mm-hmm. And I've heard from many people of my generation who are so frustrated with the medical profession now that they're just running out the door. And these are very senior established people because they feel they can't practice medicine anymore.
Right. We see that a lot in the physicians and nurse practitioners that we interact with. They're not feeling great about their careers because they're not getting to do the healing work that they set out to do.
So I started to work with a healthcare company. Preliminary, we were developing a proposal. It really didn't go anywhere, but it was to create what I called polyvagal informed navigators. which would be a person who was the guardian or the navigator for the client. And so you didn't have to change the whole system. You just had to make sure that someone was with the client to help them navigate and who was understood the principles of polyvagal theory, which were how you engage the person affects their physiology, it affects their bias in life, their awareness of other. And if you want people to be healthy, you better treat them nicely.
Let's talk a little bit about some of the technology, so to speak, that you've developed over time for interventions to work with this system that we're talking about here. And I know a little bit, not much, about the sound and the Safe and Sound protocol. Do you want to say a little bit about that?
Sure.
Just a starting point.
Sure. And actually, it fits in well with your interest in neuroception, or where do the signals come from. So if we looked at a mother with her baby, she's using this prosodic voice. If we look at virtually any pet owner who has a dog or a cat, how do they talk to their dogs and their cats? They're using hyperprosodic intonation of voice. And if they have a dog, if they don't do that, the dog will detect that the dog might think they did something wrong and literally huddle down on the floor and may urinate on the floor, feeling that they're being disciplined. So the point is that we're sensitive to babies. We're sensitive to our pets. Are we sensitive to each other? And the answer is no. That babies are babies, pets are pets, but somehow when we interact with people, it's not how I say things. It's actually the words, it's syntax. It's not how sound is presented. So I decided I would develop a system that would recruit the social engagement system through the portal of acoustic stimulation, and in a way function as if it were an acoustic-driven vagal nerve stimulator. In a sense, would calm people, make their bodies accessible. Now, in general, this works extraordinarily well with most people, especially children who are on spectrum. They may, so we say children on spectrum, we don't know if they're autistic or not. We know that they have hypersensitivity, social withdrawal, but we don't know if it's a true disease or are their bodies in a state of constant threat. So if you can turn off the threat, what happens to the features? Is it a cognitive disorder that can be worked with or adjusted with? But even if it can't be, the quality of life of this whole subset of the population can be improved if state regulation isn't a problem. If you talk to teachers, you ask them the question, what's the major problem in your classroom? It's going to be state regulation. And behavioral technologies don't work. But the Safe and Sound principle enhances state regulation in many high probability of a hit. Now, the interesting part was, since I talk so much in the world of mental health, especially in trauma, the trauma world embraced the Safe and Sound protocol. And this is where we learned so much, because for many, it was very, very helpful. They were coming back saying, well, life's different. My husband now looks at me differently. It was really all these wonderful things that I understand why life is, it's really beautiful. But then you get these counterindications where people would become destabilized by it. And it took a few of those cases for me to truly understand what was going on. What was going on, the cues of safety were triggers of vulnerability. So it's like, I'm listening to this, my body becomes like this. Now the cues of this ventral opening become cues that I could get hurt. And suddenly I can't sit in the chair anymore and I'm destabilized. And so through insightful trauma-informed therapists, they start to build a model of intervention that has some of the similarities with SE. It's titrated. And they use the feedback for psychoeducational discussion. What are you feeling in your body? And what you start learning is that the trauma history resulted in total numbness or dissociation of their cognitive worlds from their body. And now their body was talking to them, and it was talking too fast. And it was scaring them, literally scaring them. And so you had to, in a sense, work with them in a very slow level. And there are several people who are somatic experience trained, SEP providers, who have been trained with the SSP. And what they say is that it accelerates somatic experience in treatment the modest one was 6 months, but people were saying more than a year. It's changing the platform that they're working with. And then many other somatic-oriented therapies were also saying it's changing the state of the person before they actually get to work. So we're trying to do some pilot work to see if a psychotherapy, even more traditional psychotherapy, benefits by a few minutes of listening to the safe and sound protocol before the therapy. But it's not just listening for a few minutes. It's talking about your feelings while listening. So it's, again, this journey of re-embodiment. So the answer is this intervention was designed because our neurophysiology in this evolutionary change from asocial reptiles to social mammals resulted in our middle ear bones breaking off. So it sounds so esoteric. But when those middle ear bones broke off, it enabled humans, or not just humans, mammals, to hear acoustic sounds in frequency bands that reptiles couldn't hear, higher frequency airborne sounds. And the middle ear muscles that regulate these little bones were all about social communication. It was about cooperation and communication of the species to talk to itself, conspecifics in a dangerous world. So I start to label what I call a band of perceptual advantage, that when we're safe, we can hear or process, listen might be a better word, we can process acoustic information in this frequency band. But when our body's in a state of threat, we can't even detect what's there. We hear low frequency sounds. And this is frequently observed in trauma survivors and other mental health issues, including autism. Low frequency sounds result in a hyperacusis, but the processing of speech is very difficult. They can't clearly extract speech from background sound. And so it's that social engagement system. And when you modulate that, let's get that system working, it's being regulated in the brainstem in the same area that regulates that ventral vagus. So you start seeing this whole array of changes, including changes in gut function. In fact, we have a clinical trial going on now with Ehlers-Danlos to see if we can decouple the gut problems from the disorder by giving cues of safety. From a medical perspective, we finished a feasibility pilot study of one individual with Parkinson's, and we're putting it together to show the videos and the acoustic processing of that person's voice. And it had a remarkable effect. It was slow. It couldn't go through the normal protocol, which is 1 hour a day for 5 days. It took several weeks to go through it. But they are remarkable changes of recruiting systems that were assumed to be dysfunctional. And I think the model, and this is what I've been writing about recently, is that many of the diseases or disorders that we think include these hypersensitivities, that these hypersensitivities are not part of the disease. They're part of a response to having the disease. They're part of a threat reaction. They're part, even in cases of inflammation. Our body reacts to this. And the question is, our body hasn't got the signal to say, not necessary to react anymore. And the safe and sound protocol is really saying you don't have to react to those things. So I think the future, this is really where I get into this optimistic pitch, that if we rethink about disorders and we start to notice that so much of medicine and medical problems, whether we talk about mental health or comorbidities that are manifested in the body, they all tend to be the syndrome of which that social engagement system is turned off. The ventral vagus isn't working. The sympathetic is it's overreactive, and it often oscillates with the dorsal vagus going into a shutting down or into a diarrhea, constipation, oscillating model. It's because they're not being constrained by the safety signals coming from the ventral vagus. Now, if we get the system on, what happens? It doesn't necessarily cure the disease. It just redefines what the disease is. And the upside of this, it changes the quality of life for so many people.
I mean, are you, just to build on your optimism for a moment, do you feel like technology is really going to be a major component of dealing with this issue?
I think the technology is not a high tech. It's not as high tech as one might think. That once you understand the principles of what is the signal that our bodies want to hear, the next question is what are the signals that we can use to document that the body has responded. So it requires signal processing of autonomic responses, which are available, and we're trying to optimize the packaging of that so users can see it happening in real time. I was part of a team that invented a camera that measures physiology from a distance and hopefully will be embedded into something like a webcam. So as a therapist, you could watch the autonomic responses of your client and see if the vagal system was coming on board. And you can use that in the psychoeducational part of replaying it with your client, where they can see their body reacting and then become more embodied. So the question is, the development of the stimulation model is there, and we're learning more about how it can be delivered. The second part is we can measure the impact because the polyvagal theory comes with in a sense, a theory of how to measure it. So it measures its function through that ventral vagal system, and we now have portals that we described of respiratory sinus arrhythmia and now vagal efficiency. And I'm sure there'll be more variables over time, but just with those two, we'll see a lot happening.
Speaking of webcams, in the world of pandemic and social isolation and two-dimensional teletherapy, what would you suggest to the providers in the audience who are doing, like us right now, we're on Zoom and are not having the social engagement in 3D with their clients right now in terms of supporting them for, I would say, optimizing their vagal fitness?
Well, there are a couple of parts to this, and I'm listening a lot to what I hear from providers all around the world. And that is, for some of them, first from a provider's perspective, they think that it's working real well on Zoom. And part of it is the feedback they're getting from individuals, especially those who have trauma histories, that the person with the trauma history is safer in their own home. They don't have to go out to the clinic. They don't have to be in the outside world. And if they're uncomfortable, if the therapist's eye gaze is too much for them, they ask the therapist to turn the camera off for a while. So there's an agency, and that's working well for that group. For the therapist, some of them, I got two different types of information. One was it's great. The other one is this is exhausting. Because what the exhausting part was telling me that maybe as therapists, they weren't always as engaged as they thought they were with their clients. And so now they're focused and they realize that if they're not there, present with the client's going to detect them because they're now saying, the camera's on me. So you get this kind of reversal. For me, not being a therapist, but giving webinars and these podcasts, I find that it's not the same as the metaphor I would use having a cup of coffee at the Starbucks, which would be really nice, but it's better than nothing. And my body seems to like it. And so when I hurt my back about a year ago. I twisted it and I was in really excruciating pain. But I continued to do webinars, and some of them were full day webinars. I was pain-free while interacting. Now, when I was done, I was excruciating pain, but it meant to me, even in my own little pilot study, that the social engagement system was working while I was online. And so, it became my life. It's become all of our lives. Now, the question for me, and it's probably for you and everyone else, is how do we go back into the other world that we came from? And this becomes very polyvagal to me because my autonomic nervous system is somewhat retuned. So when I go out, and I've been vaccinated since the end of January, I don't go out that often. I went to Costco's and it was overwhelming. And the issue is the presence of others bothers me. And I'm a social being. And I've turned down all of my invitations for 2022 already I'm not ready. I don't feel comfortable in being, part of me, the brain part wants to give hugs and be around people, but the body says, this is predictable where I am now. It's a retuning. I think we have a lot to go through, and our colleagues and friends who survived the virus, who got infected and survived it, their lives are also challenged because there's remnants in their system of the consequences, including a retuned autonomic nervous system. So long haul COVID is another one of these what I call piggyback disorders of autonomic retuning. And we have to give the body another clue. And things like Lyme disease, they're all the chronic fatigue, the types of disorders that are probably coming to your clinic. These are disorders without a clear disease model. And they're real because the autonomic nervous system is in that state of threat. So if they get redefined by saying you're stuck in a state of threat, don't tell a person they're stuck in a state of threat, but you see it as that, and your nervous system needs to develop more plasticity, more flexibility, and that means it has to start internalizing cues of safety.
It certainly is more palatable to me to be told that you're stuck in a state of threat than it's all in your head, for example, which is what
I think that's criminal. So I wrote a foreword for a book on Ehlers-Danlos, and to write the foreword, I decided I must read the book. So I read 560-page book, and it is a sad story of these were state-of-the-art physicians working passionately in this area, and many of them had the diagnosis, and you start seeing common features. So it's a collagen disorder, at least hypothetically. However, trauma tends to be the cue that sets it off. So you now start seeing these trauma and dysautonomia. So you start seeing what I'm talking about as part of these disorders. The body has this vulnerability. Suddenly trauma comes, it gets stuck in this autonomic state, and this whole cluster of symptoms, including anxiety, gut problems, all these things, and pain, start really coming out. And many of these individuals have been told by physicians that nothing's wrong with them.
Right. Yeah, it's what we were taught to say when we didn't understand what was going on.
Yeah.
Basically.
It's such an exploitation of a group of people. And the word, like medically unexplained symptoms, I never even heard of that term until a few years ago. And that term is really a term that says this is an area where polyvagal theory is useful. And in fact, it's an area in which many practitioners are using the safe and sound protocol with great success. So cues of safety change that symptomatology of the systems, because those symptoms are related to the body being in a state of defense.
Well, let's go to our last question. We ask the same question to everyone. If you had a billboard that every human would see once in their life that had a paragraph on it, what would you tell them?
Well, I would tell them to listen to their body and respect what it's telling them. And we have different words. We say like honor your body or have self-compassion, but it's really saying your body's trying to tell you something. Listen to your body and develop a vocabulary to understand what that body is telling you. And that's, I view as part of my job, is to give that vocabulary to science and to the medical profession.
Thank you.
Well, thank you for so many decades of commitment to that mission, and it's very encouraging to me that your work has become so widespread, and it's our honor to do our part to get further out there.
Well, thank you, but I will also tell you that as I sit back, and it's been a long journey, but the journey was really that, to me, much of this was obvious. We all have kind of this view of the world. So even though it appears to be kind of almost a radical paradigm shift, it was really the obvious thing that I saw, and I just needed a vocabulary. I needed a toolkit to measure it and a vocabulary to describe it. And the reason it's getting traction is because people who start to learn about it said that describes who they are.
Right.
So it has this validity, intuitive validity.
Sure. Yeah. It's there's always an inner knowing.
Yeah.
Somebody can put words to something you aren't able to put words to, and then you're like, oh, those words are actually matching my experience.
Yeah. And I get emails from people who tell me that once they got literally the map from reading my work, their personal narrative made sense, and it changed their life.
Yeah.
Yeah. Well, thanks so much for being on the show and everything you're doing.
Well, thank you for inviting me. It's been enjoyable hour.